All right. Thank you everyone for your patience and good evening today for joining the session. And today we are doing the third part of our eight-part NEET PG prep series. This series aims to provide important information on exam preparation through subject matter experts from Elsevier. And so far we have covered obstetrics, gynecology, and pediatrics, and the recording of those sessions is available on our Instagram channel. And today we will be diving into orthopedics with Dr. Sood. Now Dr. Sood is a director and professor at Department of Orthopedics at Lady Hardinge Medical College, New Delhi. He is the author of the Textbook of Orthopaedics, which is now in its second edition, and he has over 24 years of teaching experience, and he's been involved in actively in research projects throughout this tenure. So today we will be asking him some questions about the topic, and if you have any questions of your own, you can share those in the chat section today. So thank you, sir, for joining. And if we can just start the session today by talking a little bit about the composition of orthopedic questions in NEET PG paper, and if you can elaborate a little bit on the type of questions asked in the paper.
Yeah, first of all, good evening and many apologies because of some, I think, some defect in the device. I was 15-20 minutes late, but after I've apologized, let's come to the question straight. So the question is that what is the composition, isn't it?
Yes.
Of the orthopedic? Yeah. So let me start with it that, first of all, orthopedics is not a separate subject as far as NEET PG and undergraduation is concerned. It is part of surgery. So there are total, there are total 200 questions in NEET PG, all of you know. Out of that, 45 questions belong to surgery. And in these 45 questions, orthopedics questions will be 5 to 7, MCQs will be there from orthopedics, right? And other subjects being dental surgery and anesthesia. So, what we are trying right now is that questions might be in a single question. They might try to ask you knowledge from orthopedics, knowledge from radiology, knowledge from surgery, like that. For example, I was searching from the past question bank, so I came across one of these questions. Listen to it carefully. A child is brought to orthopedic OPD with a deformity in the lower limb and hypopigmented skin lesions. The X-ray of her thigh is shown below, and what is the most likely diagnosis? Now, what all specialties does this question touch? Number one, it is orthopedics. A child is brought to the orthopedic OPD with deformity in lower limb. Deformity in lower limb straight away goes to orthopedics. Hyperpigmented skin lesion. What they are trying to test is they are trying to rope in dermatology. That is not part of surgery, but yes, dermatology. The X-ray of a thigh is shown. That tries to rope in radiology. And now they are asking what is the diagnosis. So in a single question, you have been tested not only for orthopedics, but also for radiology and also for dermatology. So this is the kind of questions, you may not be, you may not be asked pure, rote questions. That what is the value of serum alkaline phosphatase? Those days are gone. What is the normal value of serum calcium? Right? Because what is important is to apply these values, right, to your clinical sense. And so that is why we have done away with questions like that, and more questions are analytical and clinical based, right? I hope I was clear. Then we can have another, I can give you another question, example. Listen to this carefully again, right? A patient at orthopedics OPD complains of troubled sleep at night due to numbness and tingling sensation involving lateral 3 digits, right? His symptoms are relieved as he lays his arms hanging from the bed. Which of the following option correctly describes his condition and the test used to assess it? So if you carefully read this question, it is not only orthopedics. Yes, we know it is carpal tunnel syndrome, but what else it is testing? It is testing your skills in neurology. So, the questions will be framed like that, that a single question is testing multiple skills, right?
Right.
I
So,
hope I have
sir,
made myself clear. Yeah.
yes, sir, yes, sir. If anybody has any questions, please do share them in the chat. Sir, moving on from here, if we were to talk about specific topics that are covered in the exam, besides from specifically from the subject area, what would be the key topics that one should prioritize while preparing for the NEET PG exam?
So, recently NMC announced CBME,
Mm-hmm.
isn't it? The competency based. So look for competencies, right? Your questions will be usually from the competencies. What are the competencies in orthopedics? Competencies in orthopedics are basically, they will hang around the common OPD conditions and trauma, right? So as far as prioritizing is concerned, I should advise you that you should first of all read and learn traumatology. That includes management of fractures and dislocations, including their acute and chronic complications, right? Now, what are the acute complications? Like acute complications means like compartment syndrome, right? The nerve injuries which associate with fractures, right? The plaster syndromes. So all these acute complications as well as chronic, like non-unions, like malunions, right? So you should prioritize all these. And not only you will find that the textbooks are describing them, you will also find these cases in your ward. So whenever you will go for ward postings, these are the kind of cases you are going to get, right? Usually those cases will be shown to undergraduate students, which are painless, right? So you're more likely to have chronic cases like malunions, non-unions, and sequelae of the of the septic arthritis rather than acute cases. So that as far as trauma is concerned, it is usually the chronic complications. As far as rest of the things are concerned, when you will go through any book, right, you will find chapters. And in chapters, for example, in the chapter of peripheral nerve injury, what is priority? Priority is what we see daily and commonly in the wards and in the OPDs. For example, for peripheral nerve injuries, the claw hand, the wrist drop. Claw hand means ulnar nerve injury. Wrist drop means radial nerve injury. Foot drop means common penolar nerve injury. Then brachial plexus injuries. And then, as I already told you, that nerve injuries which are associated with bone injuries. For example, you know that radial nerve is commonly associated with fracture shaft of the humerus. So you must know this association and you must read about it. As far as infections are concerned, acute and chronic osteomyelitis, septic arthritis and their sequelae, they are very common in India because we are still a developing country, still struggling to combat infections. And then tuberculosis. Unfortunately, we are amongst the top tuberculosis countries in the world, and tuberculosis also affects the bone, especially spine and the hip.
Mm-hmm.
So we will get patients from the, for spine and hip. Then tumors, benign and malignant bone tumors, all are important because they are present. They can be given in your short cases. They also form part of your MBBS theory exam. And if you're well versed with tumors, you can score 100% marks as far as OSCEs and MCQs are concerned. Metabolic disorders like rickets, osteomalacia, and fibrosis. Now, neuromuscular disorders like post-polio residual paralysis. Fortunately, post-polio residual paralysis no more is prevalent in India, especially in North India. So, its space has been taken by cerebral palsy. So, you have to know the fundamentals of cerebral palsy, not in detail. Then you must be familiar with the common OPD conditions, which we commonly see in orthopedics, like in spine, low backache, PIVD, tuberculosis of the spine; in shoulder, chronic or recurrent shoulder dislocations. Then wrist and hand, uh, we should know about the common soft tissue swellings like ganglia, neurological conditions like carpal tunnel syndrome. As far as hip is concerned, now hip is a big chapter. So you have to know quite a bit of hip. including the developmental dysplasia of the hip joint, the septic sequelae, which is classical Tom Smith arthritis, fracture neck of femur and hip dislocation, Perthes disease, slipped capital femoral epiphysis. As far as knee is concerned, you will be usually given inflammatory arthritis because it is one of the commonly involved joints in inflammation, osteoarthritis. And as far as foot and ankle is concerned, you can be asked about clubfoot and flat foot. So as you must have noticed that I have basically classified according to the region. So if you are random to study in your studies, then it is a very long, syllabus. You will feel that syllabus is too long. But when you classify, then syllabus becomes, you will easily be able to divide syllabus. For example, मुझे hip में ये सब पढ़ना है, right? So there are 3 or 4 topics in the hip joint, as I told you, DDH, septic sequelae, fracture neck femur, hip dislocation, and hip is gone. You have finished hip. As far as foot and ankle is concerned, you have to read clubfoot. That is the case, and the questions will be mostly asked from this region. As far as spine is concerned, it is PIVD. So once you classify, what you have to read, it becomes easy to grasp, right? So classify in this fashion and read it in this fashion. So these are the priority areas.
Right. So apart from, you've given a list of topics, but apart from classifying as a technique to learn, do you have any other suggestions in terms of memorizing some of these topics? Also, we can touch upon the diagnostic tests that should all, like a student should know while preparing.
So, my advice will be that all of you have, 10 to 15 days posting in orthopedics. This is what I keep advising all students, right? When you come to orthopedics, you come prepared with the book, whatever book you're following, right? There are 7 regions in orthopedics, right? Spine, hip, knee, foot and ankle. In the upper limb, you have shoulder, elbow, wrist and hand, right? So there are 3 in lower limb, 3 in upper limb, and 1 spine. There are 7 regions. So give 1 or 2 days to each region, right? So when you come to the posting, come prepared. See, request your faculty to show you knee cases in 1 day, hip cases in 1 day, elbow cases in 1 day, wrist cases in 1 day, like that, right? And finish your orthopedics in these 15 days posting. Once you come prepared and you have seen the clinical test being applied, it permanently gets imprinted on your brain, right? But you have to do this small endeavor that you must come prepared and do the clinical test in the ward or OPD. So once you have done that, you will never forget the clinical test, right? So do that in the OPD, and once you go back home, just try it on your, on your colleagues. So elbow, one colleague can do, hip, another colleague can do, knee, another colleague can do, right? Like that. So utilize these 15 days for preparing orthopedics and finish orthopedics in 15 days. I know you will not have more time for orthopedics than this, right? But believe me, once you utilize this 15 days time, all the tests will come very handy. Usually, I'll tell you what is asked in orthopedics in undergraduate exam as far as clinical exam is concerned. You will not be asked, a detailed clinical examination of each joint. What you are expected to know is that what is the range of motion at a particular joint? How do you measure that range of motion? How do you use measuring tape? How do you use goniometer? Right? These basic clinical skills are expected out of you, not detailed examination and detailed clinical tests of shoulder, of spine, or hip. Yes, you can read. That will increase your understanding. But this is what is required, right? Keep your measuring tape, keep your hammer, keep your goniometer handy, and use these tools as frequently as possible. If you are using these tools in your clinical posting, you will not fumble in your exam, right?
Sir, we spoke about tumors as well.
Yeah.
So can we, if you can give a little bit detailed, some information, a little bit deep dive into those tumors and how to go about remembering them and diagnosing them.
Okay. So, first, let me clarify that as far as tumors are concerned, if a clinical case is given to you of a bone tumor, it will be usually a benign bone tumor, right? Because when if you will not be given a malignant bone tumor, because malignant bone tumors are very angry looking, the patient is very painful, and the patient may be very sick. So these patients will not be given to you, right? Yes, you will be able, you will have to read about them, but as far as clinics are concerned, these cases will not be kept. So if a patient has been kept in the clinic for the exam with a bone swelling, it will be usually a benign bone swelling, right? So we must know that benign bone swellings are uh, are basically of two types. One, they are cystic bony swellings, and another, they are usually solid bone tumors. So solid bone tumors are something like osteochondroma, benign solid bone tumors, right? And the cystic swellings are the prototype is a giant cell tumor, GCT, right? And rest of the cystic swellings are just differential diagnosis of GCT. Okay, so chondroblastoma, brown tumor of hyperparathyroidism, then fibrous dysplasia, simple bone cyst, aneurysmal bone cyst, right? These are all differential diagnoses of GCT. So keeping GCT as a prototype of a benign bone tumor, you can learn these 8 differential diagnoses which I have just told you, right? Now, once this, you know, the specialty of tumor is that you will be grilled more on X-rays rather than on clinical findings. It is the X-ray diagnosis in which the examiner is interested more. So, as far as X-ray is concerned, a benign bone tumor will have sharply defined margins, right? Whereas these margins will be fuzzy when the tumor is aggressive or malignant, right? Number one. Number two, there will be sharp distinction between cortex and medulla when there is a benign bone tumor. These distinctions between cortex and medulla will go away when there is a aggressive tumor or a malignant tumor, right? And third, the usually the benign bone tumors will not invade the joint, right? Whereas the tendency of a malignant or aggressive bone tumor is to invade a joint. So clinically, when the joint becomes painful, so beware that it could be a aggressive or malignant bone tumor. So GCT, although it is an example of benign bone tumor, but can become aggressive. And when it is aggressive, it is known clinically by appearance of tenderness and involvement of the joint, right?
Okay.
Otherwise, a class on tumors is itself a 1 hour affair, right? So I've just given you a gist.
Hmm.
Okay.
So you touched upon, how to review the
Yeah.
radiological images. Can you give a little bit more detail? We were focusing on tumors. Besides that, how do you approach analyzing these images and identifying critical findings in orthopedic cases?
So, I was in the previous question, I was just telling you to, classify and be systematic. So you have to be systematic when you are reading a radiograph. Otherwise, reading a radiograph becomes a very cumbersome task and you can go wrong in it. So when you will approach the radiograph systematically, it becomes the easiest thing in orthopedics, And how do we do it? Suppose there is a, X-ray, there is an X-ray of lumbosacral spine, AP and lateral view, right? So how do we diagnose things? So we diagnose things when we systematically approach it. So in this X-ray of lumbosacral spine, AP and lateral view, we will first go for soft tissue, right? So when you will start from periphery to midline, you are going from soft tissue to bone. Okay. So once you have what are you expected to see in soft tissue? What soft tissue is there? You have to make a picture in your mind. What is there around lumbosacral spine? There are muscles, right? There are nerves and vessels. Okay. Nerves and vessels are too tiny to cast a shadow on an X-ray. So what will cast a soft tissue shadow? The muscles. And which muscle is most prominent? besides the lumbosacral spine, it is psoas major. And when does this muscle become prominent? When there is an abscess in it. So a heavy shadow of psoas can indirectly tell you that there is a psoas abscess. If there is presence of psoas abscess, it can indirectly tell you that this abscess is trickling down from some bone in some bony fragment or some bony part in the lumbosacral spine. So when you see a prominent psoas shadow, immediately it rings in your mind, oh, am I dealing with infection? And which infection is most common in India? The tuberculosis, right?
Mm-hmm.
So once you have seen the soft tissue, you come to the midline. In an AP view, what do you see from periphery to midline? So in the periphery, first of all, you will see in AP view, mind you will see the transverse processes. Just close your eyes. I'll take you through the picture. The transverse process, then the pedicles, and then the spinous process, right? This is as far as the AP view is concerned.
Mm-hmm.
After you have seen these structures, you will see the general alignment of the spine, the vertebrae, right? Whether the pedicles are aligned, whether the spinous processes are aligned, whether the boundaries, the margins of the vertebrae are aligned or not. Coming to uh, uh, the lateral view. So again, you go from periphery to center, right? So usually in the lateral view, soft tissue is not going to show you much until unless there is a posterior abscess. In that case, you will see a big shadow posteriorly. And when you see in the middle, what you will see is the vertebral height, the disc spaces, the spinous processes, right? And the journal alignment. So if you find that there is break in the journal alignment, what does it show? It means a break in the journal alignment means that either there is a deformity or there is a fracture, dislocation. Okay. Reduction in the disc space most commonly is because of tuberculosis. If there is reduction in the vertebral height, most commonly it is because of a compression fracture of the vertebra, or it can be because of metastasis, right? But in case of metastasis, there will be reduction in the disc in the vertebral height, but disc space will not be reduced. When it is tuberculosis, there is reduction in the vertebral height as well as reduction in the disc space. So I've just given you one example, and I deliberately took spine because spine has many things to offer, right?
Mm-hmm.
Similar approach for pelvis with both hips. You first see the periphery, the soft tissue, and then come to the bones, right? I forgot to mention bone density. Yes, bone density should be seen before we go on to alignment and individual parts, right?
Right.
I hope you have
Sir,
followed me. Yeah.
sir, we have one question on common challenges or pitfalls that students face while answering the questions. Like, what are the common errors or the confusing topics or type of questions that can come where students can easily make mistakes and how to avoid that?
See, first of all, I should say that the questions we as examiners will not try to confuse you as far as orthopedics is concerned. It will be very straightforward exam, right? But it becomes straightforward only if you know your subject, right? So I will not say that there is a shortcut. So these 15 days posting you have to devote wholly to orthopedics, and once you have done that, you will not find it difficult. Number two, you can see, as in any other part of medicine, we have differential diagnosis, right? Suppose a patient comes to you with a clubfoot deformity. Now, clubfoot deformity can be a idiopathic clubfoot, it can be a paralytic clubfoot, it can be a syndromic clubfoot, right? It can be a clubfoot because of cerebral palsy, it can be a clubfoot because of spina bifida. So you have to keep your eyes open and fingers sensitive enough, right? In a idiopathic clubfoot, yes, there will be clubfoot deformity, there will be a talipes equinovarus, but then there will be no neurological deficits, no decubitus ulcers, right? In case of spina bifida, yes, there will be a decubitus ulcer, there will be neurological deficit, and more important, there will be a telltale sign in the spine. When there is a talipes equinovarus deformity of cerebral palsy, you will see that the child is spastic, right? And there are no decubitus ulcers. So you have seen the deformity deformity, but you have failed to see rest of the signs, then it becomes a problem. So this is what the clinic is important for, because clinic makes you aware of other conditions other than the landmark conditions. So idiopathic clubfoot is a landmark condition, but then there are several others which will try to mimic it. So you must know the differential diagnosis. So see, don't be afraid of orthopedics. You are afraid of orthopedics because most of the students will not devote even these 15 days to orthopedics. So I'll request you to do this right away so that you are free from orthopedics and you are free to read your other major subjects. So do that in your 15-day postings.
And like you said, sir, categorize them, from
Yeah,
like
yeah,
body
yeah,
parts and study it in
yeah.
a systemic
That is
manner.
so that is very important. But until unless you will categorize, it will be random and haphazard, and you will find it very heavy. The syllabus will be very
Mhm.
heavy, right? Otherwise, it is you will breeze through it.
Yeah.
It's not difficult at all.
Sir, there is one more question. I'm not sure if, but I'll ask anyway. What are the key diagnostic criteria and management options for patient presenting with suspected case of avascular necrosis of the femoral head?
That's very intelligent question. I think the student is preparing to get orthopedics in his or her post graduation, right? This is a postgraduate question. Now, a patient with avascular necrosis, what is avascular necrosis? That means the blood vessels, which are the end arteries for the femoral head, they have been, clogged. So blood flow is not flowing to the femoral head. Now, because there is no nutrition to the femoral head, the cartilage will slowly degenerate and the endochondral bone will collapse. So the collapse will result in endochondral fractures and pain. But unfortunately, when the pain when patient comes with pain, uh, already the patient has gone to stage 2 of avascular necrosis. So
Mhm.
there is there are much less opportunities once the patient has collapsed head. If the patient comes to you early, which is usually incidental only, that you got the X-ray and MRI done for something else and you picked up avascular necrosis. If the femoral head is still round, you can do many things to preserve its roundness, the sphericity and congruency. Right? So the aim of management in avascular necrosis is to preserve its sphericity and congruency as much as possible. Once the hip has collapsed, there is nothing else except total hip replacement which we can offer to the patient, right? So you have to consider this, and very intelligent question. And the clinical signs are usually, they are general. They are not specific because osteoarthritis, it is the osteoarthritis which we clinically pick up. We cannot pick up avascular necrosis clinically, right? Avascular necrosis itself is a histopathological diagnosis, not a clinical diagnosis.
So that's all the questions that we have today. And sir, if you would like to add any personal tips from your own experience, what would it be? One thing that you
Um,
let the students know.
I'll suggest that you must read the basic examination book, the whatever book you are using, the basic examination book, basic textbooks for orthopedics. Do not neglect orthopedics because it can fetch you 100% marks, right?
Mhm.
So questions will not be, don't be wary of orthopedic questions. Whenever we are, composing questions, we are trying to uh, test your clinical knowledge and analysis of that clinical knowledge. Right? We are not interested in whether you know the correct values of, calcium and serum alkaline phosphatase, and what is the correct dose of vitamin D in rickets. We 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 hope that you already know all this. What we are what we are interested is that how you are applying this basic knowledge of your orthopedic anatomy, of orthopedic physiology to your clinical sense, right? This is what we are interested in. So you will find more and more questions to be clinically oriented rather than didactic questions, right?
All right. Thank you so much, sir. And thank you, everybody. Hope you got those tips there. Categorize your subjects, be systematic, and at least give 15 days to orthopedics. It's like you can get full marks there. So hopefully you've got the most from the session. Thank you once again, sir, for joining us today. We have tied up with AIBH, the All India Book House, and the AIBH will be offering 4% additional discount. We'll share the code with you in the chat. So use that code discount to get additional discounts from the website. That's all.
If
Thank you so much, sir.
yeah, if a final comment, if I can tell two lines about the book which I have authored for you.
Mm-hmm.
That I was talking about the clinical examination and the theory. So this is
Mm-hmm.
one book which has both. It starts with the clinical anatomy, followed by the clinical examination, the pertinent tests for clinical examination, and then it describes all the clinical situations which you are expected to know. So it's a very systematic book. And as I told you, if you will prioritize all these features with the list which I told you, you will be able to do it in 15 days. It's not difficult at all, right? So that is the beauty of this book. It is a combination of clinical as well as theory, and it is based on CBME.
Right. So again, covering all the fundamentals there within the book as well, hopefully in the session as well today. That's all, sir. Thank you for joining. We will be
Thank you.
signing off. Thank you.
Thank you. Thank you so much. I'm sorry for the delay once again.
Problem. Thank you.
Thank you.